Hi, back with another session of the menstrual cycle. In the first, we have discussed the menstrual cycle overview, key phases, that is follicular ovulation, luteal phase, and the uterine cycle, proliferative phase, secretory phase, and about the menstruation. Now, in this video, we'll discuss about the PCOS and the menopause. So, let's just start. PCOS is polycystic ovarian syndrome. Most common the gene mutation, if it is like a genetic association is there, it is CYP21. Most common cause of secondary amenorrhea, pathological cause of secondary amenorrhea, because the most common cause of secondary amenorrhea physiological is pregnancy. It is characterized by increased LH FSH ratio, leading to increased androgen production and increased theca cells. Etiology is mainly diet, environment, and genetics. So, diet, obesity, and genetics will lead to increased LH and FSH ratio, which will lead to increased androstenedione in the theca cells, and which will lead to increased testosterone, leading to hirsutism, acne, and also this increased androstenedione will lead to increased estrogen, that is estrone mainly in the adipose tissue, which is E1, will lead to decreased FSH due to negative feedback to pituitary, leading to anovulation and the follicular cyst formation. Also, decreased FSH further will lead to decreased progesterone, that will lead to anovulation, and that means infertility. In here, the endometrial receptivity is also very poor, due to which even if the patient conceives, there is increased risk of abortions. So, and also because of this etiology, there is hyperinsulinemia and insulin resistance, which leads to acanthosis nigricans, which is a clinical manifestation of insulin resistance, in which the plaques of darkened skin forms mostly around the neck, armpit area. Future complications may develop diabetes mellitus. On lab investigation, the sex hormone binding globulin is decreased and 2-hour OGTT is abnormal. Then, the most important diagnostic criteria we used in the PCOS is Rotterdam criteria. Clinical features of the PCOS can be remembered by HOMI, that is hirsutism, acne, obesity, mainly abdominal. But that doesn't mean that PCOS will occur in obese patients only. It can affect thin females also. Menstrual abnormality, infertility, Heron syndrome is hyperandrogenism, insulin resistance, and acanthosis nigricans. Now, the management. First line lifestyle modification, that is weight loss for obese patient, reduce smoking, reduce junk food and fried foods. Hormonal contraceptives, first line of hirsutism, acne, and menstrual irregularity. GnRH agonist, Lupri, clomiphene citrate, first line of infertility, metformin insulin sensitizing agents, laparoscopic ovarian drilling done when the resistant to medical therapy. Now important is on USG. According to the revised ASRM criteria, we will see more than 20 follicles, each of size 2 to 9 mm and a volume more than 10 ml. This is all about the PCOS. Now we'll cover the menopause. So, menopause is permanent cessation of the menstrual periods due to depletion of the ovarian follicles. Loss of estrogen and progesterone from ovary. Now here you can see menopause is loss of estradiol production from ovaries. Also it will lead to decrease inhibin. No inhibin, so no suppression of FSH will lead to increase FSH, and this increase in the FSH is an early finding in the menopausal females. Anovulation is also caused during menopause, so decreased progesterone and amenorrhea. This amenorrhea will last for 12 months and then we declare this as a menopause. Androgen decrease leads to loss of libido. So, coming to the symptoms of menopause, first, the median age for menopause is 51 years. Its symptoms are the first and foremost irregular periods or skipping of periods, heavier or lighter periods than the usual. Hot flushes, which is subjective sensation of warmth, last for few minutes then pass and followed by the shivering sometimes. This is due to narrow thermoneutral zone due to decreased estrogen. So management is reassurance in cases of in mild cases or in a moderate or severe cases HRT hormone replacement therapy. This is a best and a first line of management. Then insomnia, vaginal atrophy, also due to decreased estrogen. This is thin, dry, friable, inflamed vaginal walls. Vaginal dryness is a main symptom of GUSM or you can say GSM, genitourinary syndrome of menopause. Management is local estrogen, lubricants, moisturizers, or HRT. HRT will also help here. Then loss of libido, osteoporosis, increased risk of fracture, bone density decreases due to decrease of estrogen. Associated with the most common complaint of backache and most common fracture are a vertebral fracture more than the neck of femur and more than the Colles fracture. On X-ray of vertebra, codfish appearance can be seen, very specific for osteoporosis. Then decreased estrogen will lead to decreased bone mineral density, which can be calculated by T scores or Z scores. So DEXA is done for T score, which will be more than equal to 2.5. T score is usually negative, but here T score will be 2.5 more than that. On Z score, it is less than -2. Management, the first line is bisphosphonates associated with severe gastritis. So we advise patient to sit for 30 minutes or 1 hour after taking the bisphosphonates to avoid its side effect. Then other is calcium, vitamin D, SERM, cell calcitonin, tibolone and teriparatide. Then HRT can alleviate the symptoms but carries a risk of breast cancer, serious that is cardiovascular events, DVT, stroke and MI. So this is all about the menstrual cycle overview. We have completed then PCOS and menopause. If you want to know more, you can comment. And if you want this chart, let me know, I'll share. Thank you.